So good evening, everybody. I hope you can hear me okay. I'm just going to start this webinar, the first of our series for the menopause, where we're going to have a bit of an overview on what the menopause is, when it's likely to occur, and how you might manage it or support someone going through the menopause. So thank you for joining. And just to say, I am recording this webinar so that we can share it and you can look at it again if you want to, but also for those that weren't able to attend. You will have the opportunity this evening to ask questions, and you can use the question function for that process. In fact, I can see a question's already come up. So it's asking for any captions, please. Not sure what's meant by that. If you want to elaborate on that, that would be great. Anyhow, let's get started. So I'm going to, first of all, say a little bit about Remedy Health. We're an independent and private healthcare clinic and pharmacy. It's a fairly unique and special model here in the UK, and we have won a number of awards since we opened in December 2021 on the back of the COVID pandemic. Our core aim is to provide you and others as much advice and support so that you can control your health and be the best that you can. So we offer a range of different services, right the way through from diagnostics through to prescribing and supply of medicines. I'm a pharmacist. I'm the owner of the business and founder of Remedy Health, and we work with a multidisciplinary team led by pharmacists, and for my own part, I've been a pharmacist for over 36 years now. We have independent prescribers on site, but we also have a medical advisor and a skin doctor working with us. We pride ourselves on having relationships with other healthcare providers, and so we do operate a referral-based model where if our care needs to pass on to someone else, we'll make that referral. Based in Winchester, very lovely part of Hampshire, but we do also offer remote consultations, and that might be relevant for some of you attending today who live a little bit outside of Hampshire. I think it's important to mention that everything that I'm going to talk about this evening has an evidence base to it, and that is really important to us to make sure that what we recommend and work with are based on good, sound evidence. A little bit about me. This picture I found was in 2012. So that was over 10 years ago, and we were on holiday actually in America. And the reason I put this photograph up of myself, my husband, and my family is that I was at the sort of peak of my perimenopause at that time. I was 48 years old. And whilst I'm smiling on this photograph, it really does hide a multitude of issues that I was going through at the time. And importantly, as a healthcare professional, 10, 11 years ago, thankfully things have moved on. But at the time, I didn't really recognize what was happening to me. Incredibly heavy periods. I, at times, was crippled with anxiety, certainly didn't recognize myself. And in fact, my eldest son, Matthew, met us at the airport, having traveled over from New Zealand, and he thought I was dying because I just wasn't myself, lacked a huge amount of energy. I had no energy, actually. I was literally crawling from day to day. Thankfully, things have changed. And now as I approach the latter stages of my 50s, just had my 59th birthday, I'm thriving and incredibly healthy and feel great. But it wasn't the case back then, 10 years ago. So let's get on with the evening. What are we going to cover? So we're going to explore what the menopause is, why it happens, when it starts, and if and when it ends, how to manage menopausal symptoms, whatever your age, and how that changes. Actually, it's a bit of a journey. Things don't stay the same, as we know, with our health. And that's certainly true of many people's experience with the menopause. We're going to recognize different symptoms as we go into the menopause, and how we can support that with lifestyle, other support, but also medicines, in this case, hormone replacement therapy, or HRT, as I'm going to refer to it. We're going to also explore the broader changes our bodies go through as we age and what happens to us as our hormones diminish. So we're going to look at the long-term health benefits and any potential risks associated with HRT. But I do think it's important to recognise that we're all individuals as we go through this phase of our life, and it is called the change, and for good reason. And whilst I'm incredibly happy to answer your questions as we go through the or as we get to the end of the presentation, actually, I won't be able to answer very specific individual questions around somebody's specific health history, but I will do my best to answer those more generic questions. So, this is the first of the series. We are going to go into more detail around the perimenopause in our next talk. We're going to also explore in our third talk specific symptoms around vaginal dryness, urinary tract infections, urinary symptoms, so that's frequency and bladder sensitivity, as well as recurrent infections in that area. It's referred to as the genital urinary syndrome of the menopause, and which is a bit of a mouthful, or GSM, previously known as vaginal atrophy, which is a pretty grim term and doesn't properly describe what's going on. It is something that just worsens as we age, and is, whilst it can affect perimenopausal women, it is particularly prevalent in postmenopausal women. So we're going to explore that specifically in the third of the series. And then as we move into the fourth, we're going to look at HRT in more detail, and then we're going to look at testosterone specifically in the fifth of the series. So if you enjoy this evening, then do sign up for the others. So, bit of a biology lesson. When I was thinking about how to start this presentation, I thought, let's go back to some basics about hormones. We talk so much about our hormones from when we're teenagers, adolescents, right the way through to menopause. But what are they and what do they do? And they are more broad than our reproductive and sexual hormones, which is, of course, where the perimenopause and the menopause come in. You might remember back from biology lessons that hormones are chemical messages that are found throughout our body with a range of different functions, and they tell us how to respond. So they're involved in growth, in our development, our metabolism, our emotions, sexual and reproductive function, sleep, and blood pressure, to name a few. And they are intimately linked with each other. They originate in our endocrine system, our glands, and these glands create and release hormones into our bloodstream. They then go off to all our organs and tissues, and then receptors in our cells in those organs and tissues recognize and respond to those hormones, and essentially keeps our body in what we call homeostasis, or tries to keep our body in homeostasis. And of course, it's the malfunction of that that causes a number of diseases, and for us to very quickly feel unbalanced and not in a good place. And that can range from malfunction of insulin, for example, from the pancreas, which can lead to diabetes and various conditions around that, through to issues with our reproductive hormones and thyroid, for example. So a bit more of that in a minute. But unlike our nervous system, which uses electrical currents and chemicals to communicate, hormones can be slower. They can be quick, like insulin, but they can act over a longer period of time. Relative to our nervous system, they are slower. So that's a bit about our hormones. And where do they originate from? Well, I've already mentioned our endocrine system. But where are they, and what is that? So it starts off with our hypothalamus, which is located in the brain, and that is really the sort of the father of all endocrine glands. It contains the pituitary gland, which is also in the brain, and it essentially links our endocrine system and our nervous system together. Pituitary gland is our master of hormone secretion, and it does control our other glands, and it is relevant very much in terms of our reproductive system and the instructions it gives our sexual glands, our ovaries, for example, and testes in men. It's a pea-sized gland in the base of our brain, and it receives those signals and secretes hormones from the hypothalamus, but also produces its own hormones. So clever little thing in our brain. And there can be dysfunction of the pituitary gland, which can cause various issues. We then have our adrenals, if we're working down the body, which are located on the top of both kidneys, and these produce hormones in response to stress. So the most obvious hormones that come from the adrenals are cortisol hormones, but there's a range of others as well. Adrenaline, you'll have heard of, comes from the adrenal glands as well, and it helps to regulate blood glucose and metabolism, also produces testosterone in very small amounts, and helps with the sexual response. Now moving into your ovaries, these are our most important with respect to the menopause and what happens to us through the perimenopause and in our reproductive health. These are our two small oval-shaped organs in the pelvis, located on either side of the uterus or womb. Now, the ovaries produce estrogen, and this controls menstruation or having periods, and progesterone. And progesterone is the main hormone that supports pregnancy, but also has other functions. And our ovaries also produce testosterone, which, yes, ladies, is an important hormone for us. We have the pineal gland deep in the brain that produces melatonin, which is important in our sleep-wake cycle. And you can see how all of these start to link very closely together. We've got our thyroid gland, which is in the base of our neck. It's a butterfly shape. And our thyroid hormones regulate our metabolism. And you may be aware of conditions such as hypothyroidism, which is a reduction in thyroid hormone in the body, which means that we get sluggish, we put on weight, we feel really tired, we get dry skin, for example, lose our hair. And it's often a hormone that we check for during the perimenopause and menopause, because many of the symptoms associated with hypothyroidism and actually hyper, which is an overactive thyroid, can be mistaken for perimenopausal symptoms and vice versa. We have a parathyroid gland or glands. They're just behind the thyroid, and this is important in maintaining adequate calcium stores and protects our bone health. Again, an important aspect actually, which is sometimes overlooked during the menopause, around making sure that we maintain bone density. And then I've already mentioned the pancreas, which is in our upper abdomen, behind our stomach and in front of the spine. The key hormones here are glucagon and insulin, and these regulate blood glucose. So that definitely was a throwback to the biology lesson, I know, but important to put in context, because often we think about perimenopause and menopause in terms of being those main reproductive hormones, of course, and we're going to go into those in more detail, but there is an intimacy with all of these other hormones as well, which is important, and other systems do go wrong. So let's focus on estrogen. Estrogen is central to the development and functioning of our reproductive systems and for development of female characteristics, for example, breasts. But estrogen also plays an incredibly important role in bone health, memory, our cognition, so our brain function, and cardiovascular health. And there are estrogen receptors in cells throughout our body. So it's broadly described in three types. So estradiol, this is the main form during our reproductive years, and in fact is the main hormone, or is the hormone that we replace with hormone replacement therapy that we apply through the skin, for example. Estrone is also an important hormone, but it's the major type of estrogen produced in postmenopausal women. It has a weaker biological activity than estradiol. It's important to note that whilst estrone is produced by the ovaries, it is also produced by fat cells. And in fact, the more fat we carry, the more estrone we'll have in our body postmenopausally. And there is an indication that overproduction of estrone within the breast may be associated with the development of breast cancer. One of the reasons is hypothesized that women who are overweight and obese are at much greater risk of breast cancer than those who have a normal weight. So the other hormone is estradiol, which is the main form during pregnancy. So estrogens are mostly made in the ovaries, small amounts in the adrenal glands. And as I mentioned, they regulate the menstrual cycle, preparing our bodies for pregnancy. Each month, we know the ovaries release an egg, that's called ovulation. And at the same time, our hormones are preparing our uterus for pregnancy. I mean, that's essentially what this is all about. It's about preparing ourselves for reproduction and carrying a baby. Now, if the egg isn't fertilized, then the lining of the uterus is shed through the vagina, which we know as a period. Now, I'm not going to go into the menstrual cycle in huge detail, but I wanted to put it up here. First of all, we're just incredible human beings in terms of all this happens for most of us on a regular basis, pretty much clockwork, again, for the majority of us over the course of a 28-day period. But whilst estrogen is the main hormone we talk about during perimenopause and menopause, and is also the hormone we focus on for hormone replacement therapy during the perimenopause and menopause, there are a number of others that you have probably heard about and might be relevant as we go into tests you might have heard from and other aspects of hormone care. So you see there on the chart that we've got hormones produced in the brain. They're called human gonadotrophic hormones, and their two main ones are follicle stimulating hormone, FSH, and luteinizing hormone. Now, FSH is released from your pituitary during menstruations to stimulate your ovaries to produce estrogen. So it's really important to tell your ovaries, it signals to your ovaries that you must be producing estrogen. And it's important in the context of perimenopause or menopause is that it's used as a marker for women who have thought to go through a very early menopause known as premature ovarian insufficiency, or POI. This is because FSH releases in higher amounts to try and stimulate an ovary that's failing. So if we see a consistently high level, it does suggest that ovaries have failed or are failing because that pituitary gland is having to work harder to stimulate the ovaries. It's not the most reliable of tests, and actually once we get to women over 40, we focus much more on symptoms and also what's happening to periods, which may or may not be indicative of an early menopause if it's happening before the age of 45, or, as I mentioned, premature ovarian insufficiency, which is a statement associated with those that go through the menopause below the age of 40. And about 1 in 100 women will do that. Luteinizing hormone, again, released from the pituitary, is released at ovulation. You can see it peaks and falls very quickly and causes the ovary to actually release an egg. Now, progesterone is another hormone that you'll come across and is important for hormone replacement therapy. We'll talk about that in a minute. It's used to balance estrogen and is often referred to as a relaxing hormone. So in the body produced naturally, it tends to rise and does rise after ovulation and dominates the second half of the cycle, which is known as the luteal phase. Now, its main role is to control the buildup of that uterus lining and to help to maintain and mature it if there is implantation and a pregnancy. Testosterone, mentioned already, important for both men and women. In fact, we're going to have a whole webinar on testosterone. It's produced by the ovaries and adrenal glands, and it's important to maintain muscle and bone strength, enhances our sex drive, and gives us an overall sense of well-being and zest for life. Many women also find it can help with mood stamina, reduce brain fog, and improve memory. Now, the thing about testosterone here is that it's pretty stable during a monthly cycle. It rises slightly during ovulation. I guess that makes us want to have sex more, which is conducive with a pregnancy in terms of keeping the human race going. But otherwise, over a period of time, long period of time, it declines. And I guess the reflection on all of this is that this happens, of course, without us knowing or thinking during the course of the month. Some of us might respond quite significantly to these fluctuations of hormones during the monthly cycle. Certainly, many of us will have experienced a premenstrual syndrome, or even worse, PMDD, which is a much more acute disorder related to those hormone changes. But during going into our perimenopause and menopause, these hormones start to be more erratic, and we'll talk about that in a moment. So let's talk about moving into perimenopause and menopause. I've already indicated that it can happen earlier, and in fact, sometimes the individuals go through a menopause as early as their teens, very shortly after their first menstrual cycle. So that's an extreme situation, but it can happen at any age. And I think that's an important message, because frequently the symptoms associated with menopause and perimenopause can be confused for many other conditions. Now, the clinical definition of a menopause is when you've not had a period for 12 consecutive months. And when you come into a clinic, we'll often ask you, when was your last period, if you're not menstruating anymore. And that's actually quite a difficult question to answer, I think. I certainly wouldn't be able to tell you when my last menstrual period was. It was sometime in my early 50s. But also, if you've got a Mirena coil, then that would have, or an implant, that would have affected your periods, and you may not have had one for a couple of decades if you'd had a Mirena coil put in and changed on a regular basis. It's also one of those things that we spend a lot of our reproductive years either trying not to get pregnant or trying to get pregnant. And it's during those more reproductive years that we're perhaps more focused on when our last period was, whereas as we sort of drift into our late 40s and early 50s, that might become less of a focus for us. So I think period trackers that track symptoms of the perimenopause can be incredibly helpful, just to keep a record of when that was. So perimenopause is a time of transition, and that's any time from when your hormones start to decline and symptoms start through to that year post your last period. So generally speaking, it begins in the early to mid 40s, although, as we've said, it can be earlier and it can be later. Now, some women, those fortunate women, have no symptoms during that phase of the perimenopause when hormones are fluctuating. But whilst some women, including myself, can be significantly affected to the point of not being able to function. And it's worth noting, sadly, that this period, the perimenopause and sort of into the menopausal period, is the highest risk for women of suicide, to take their own life and to die of suicide. So it is an incredibly important issue, and for us to get right. But it's also an entirely unique experience for women. And actually, my own experience would be that even for one person, n equals 1, it's certainly been different at different phases. So how do we recognize the perimenopause? Well, changes to periods, menstrual cycle is usually affected. It might get longer, it might get shorter. The periods may be closer together. You might have a few good periods of normal for you, and then suddenly you get a random missed period, or one that's particularly heavy. Personally, I flooded. I had awful heavy periods that were about 2 to 3 weeks in duration, and it seemed at one stage one was merging into another. And then suddenly they stopped. So again, very, very different for different people. The changing estrogen means that you may not always release an egg, and so that has an impact on the cycle. So usually you recognize it down to changes in the menstrual cycle combined with symptoms. You may or may not get symptoms. But also we now know, evidence and research is showing us that some of the depression and anxiety and cognitive symptoms, so the more psychological symptoms of the menopause and perimenopause, can happen as early as 5 years prior to periods changing. So we need to be mindful of that. Again, it's very, very common for women to be offered and prescribed antidepressants when potentially it's their hormones that are causing the issue. So as you approach your last period, your levels of estrogen fall, and this stops your ovaries releasing eggs each month. Now, if you've been a sufferer of premenstrual syndrome, PMS, then mood changes and breast tenderness may become even more severe during this time, so that we know from studies that PMS sufferers are twice as likely to experience, for example, mood swings and hot flushes in their perimenopause compared to women who don't have a history of PMS. So you know your body better than anybody. And my advice at this point is to track. You know yourself better than anybody, but actually sometimes it's difficult to remember how you felt last week, how you feel this week, to see whether there's a pattern emerging. So I've already mentioned that sadly suicide is highest for women when they're in this phase of their life. But just to say, the average age of menopause is 51 in this country. It does vary across the world. And even within this country, it varies. So women, for example, with learning difficulties tend to menopause earlier. There is some genetic link. So we do know as well that it's worth, if your mum is still around and is happy to talk about her menopause, that that can be an indicator. And we also know that it can vary depending on when you started your periods. Now, all women, people born with a uterus, will go through the menopause. 1 in 4 will have very severe symptoms, and 3 in 4 have hot flushes, but that means 1 in 4 don't. So quite commonly, women think they're going through the menopause without much of an issue because they're not experiencing hot flushes. What they don't really realize is the many other symptoms that you can have, and I'm going to talk you through those in a moment. It's also worth mentioning that the menopause can also happen medically or surgically. So by that I mean it can be induced by, for example, chemotherapy, but also if you have to have your uterus and ovaries removed, that can surgically induce menopause, and that can be very abrupt and shocking to the body. I love this chart. For those of you who've been in my clinic, you've probably seen me share this graph because it really does explain a number of different things. First of all, the importance of our different hormones. So you'll see here, and this is based on an average woman, that estrogen falls from about the age of 35 and sort of goes on a steady decline with these cycles each month. But then during the perimenopause, which can last 7, 8 or more years, these huge fluctuations in hormones. And it actually makes taking blood tests for things like estrogen really quite difficult, because if we get you on a good day, then your estrogen levels might be reasonable. And then on a bad day, they could be really low. So it's this fluctuation in hormone that can cause so many issues for women, as well as the balance between the hormones and this homeostasis that we talked about earlier. Once you get past the menopause and your ovaries have sort of had their last splurge and you've got no more eggs to give out, you are postmenopausal, and your estrogen, if you're not taking HRT, is low. And that in its own right causes a number of issues, and we're going to talk about that. Testosterone, as you can see, steady decline, but important to note as well that melatonin, which has been reliably produced by our pineal gland, does also decline and reaches a low level, and is an indicator, amongst other things playing out, why sleep is difficult in this phase of our lives. This chart here literally shows us what happens to our estrogen, and it ends up in our boots by the time we reach our 8th decade. And it's really the most important hormone in terms of how we feel, symptoms wise, but also our long-term health. So I do hear many women telling me that they've done the menopause and that they've got through it. However, I do want to make a point that the effects of low estrogen last a lifetime, and many women still have symptoms, perhaps that they don't attribute to menopause, for many years after their last period. And there's also long-term health issues associated with those low estrogen levels. So it's fair to say that each woman's individual, and whenever we go through a consultation, we take into account an individual's risk associated with low estrogen, but also the benefits and risks associated with HRT for them as an individual. But in some respects, there's not a lower age limit for HRT, nor is there an upper age limit. It's really down to the individual and what they're going through and whether it's indicated for them. So we mentioned earlier that we have estrogen receptors all throughout the body, and these areas are affected by a lack of estrogen during the perimenopause and menopause. So that graph I showed you with it declining. Hormonal changes that occur during the menopause therefore lead to a variety of both physical and psychological symptoms. So I just really want to talk about the impact low estradiol has on our bodies. Essentially, estrogen is an anti-inflammatory hormone. It reduces inflammation in our body. So if we have low levels, that leads to more inflammation in the body. And our immune cells work optimally when you have enough estradiol. And actually, if we go back to some of the COVID issues during the pandemic, we knew that women, and it's subsequently been shown with research, women on HRT fared better than women who were not. And actually, women generally, gender-wise, up until the menopause, fared better than men. So estradiol is a really important hormone for us in terms of inflammation. The more inflammation we have in the body, and we have the increased risk of numerous conditions, which include cardiovascular disease, Alzheimer's, osteoporosis, and cancer. More inflammation increases the risk of disease, and that's also known as inflammaging. It's a bit of a mouthful. But menopause leads to accelerated inflammaging in your body due to low levels of estrogen. And you might have noticed this if you've seen a friend perhaps 10 years after you last saw them, and they've gone through the menopause in the meantime. What a significant difference if they've not been on HRT, it can show in their face, in their skin, in the way that they move. So inflammaging, a new term. Worth noting as well that not only does menopause lead to accelerated inflammaging in our body because of the low levels of estrogen, but a healthy lifestyle is important in reducing inflammation. So there are things that we do to our body that increase inflammation. So alcohol, smoking, being overweight and obese, eating the wrong kind of foods, not eating enough, foods with antioxidants in, for example, all increase inflammation. So I've already mentioned our lovely estrogen receptors, and low levels throw up an array of symptoms during the perimenopause and menopause. And I've got this lovely infographic produced by the Newson Health Menopause Society, which gives an indication of just how broad that can be. And I think there's sort of about 55 listed symptoms, ranging from the obvious and well-known, for example, changes to our periods and hot flushes, through to the completely weird and not so wonderful. So things like bad breath, burning tongue, heart palpitations, tinnitus, a whole plethora of symptoms. And I'm going to touch on a few of the sort of more common ones now that you may or may not have attributed to the perimenopause and menopause. So abdominal pain and other GI symptoms, gastrointestinal symptoms. So women quite frequently during this period have intermittent stomach pains and other symptoms similar to IBS, such as bloating, wind, constipation, and diarrhea. And this is because we have receptors in our gastrointestinal tract that are sensitive to progesterone and estrogen levels. And also declining estrogen can impact our cortisol and adrenaline levels, which, as we know, have an important role in gut motility, our stress hormones. We can have an altered sense of taste and smell. You might have found things that you previously enjoyed or perfumes that you liked change during the perimenopause. And this is due to brain pathways being affected by low and changing levels of hormones. I've talked about bleeding during the menopause and bleeding during the perimenopause. It can be sporadic, heavy, can be just spotting. There's a huge range. Now, there are many reasons why bleeding occurs, and so we always check these through. You can have a structural cause, for example, fibroids and polyps, but mostly bleeding changes are due to changes in estrogen. And for most of us, they're not a cause for concern. But if they persist or you experience with other symptoms, if they happen, for example, post-coitally after you've had sex, then consult your healthcare professional. We get brain fog. Estrogen and testosterone have significant roles in the brain, depression, anxiety, other psychological aspects of hormone changes. And you may have found yourself walking into a room and just completely forgetting what you were there for. And you might be mid-sentence or forget people's names, incredibly common and very frustrating. I've had individuals come into our clinic who have had incredibly high-powered jobs and just found they've had to give up those roles because they just felt they couldn't function anymore. Breast tenderness, one of the physical symptoms. This is because estrogen causes our breast ducts to enlarge. That makes sense, of course, as to when pre-period, but also when we give birth and breastfeed. On the flip side of that, you might have noticed your breasts have shrunk and certainly lost form and not as full as they were, and that's the lack of estrogen. Of course, if anything changes in your breasts that concerns you, pain, fever, lumps, discharge, changing shapes, dimples, etc., then you should seek advice and potentially have a mammogram. And I just want to mention the importance of screening and checking your breasts at this point, all part of keeping ourselves healthy. Brittle nails, dizziness, difficulty breathing, inflammation in lung tissues, decrease in lung capacity, dry eyes. We've had opticians refer people to us. Dry and itchy skin is a very common symptom during the perimenopause and menopause. And a call out here to our female bits, our vaginas, our vulvas. Just as our skin gets dry on our face and on our skin, it gets dry in that area and can cause all sorts of issues and problems. Gum disease, bad breath, other oral health problems, burning tongue can happen during this time. Hearing issues, tinnitus, commonly heart palpitations. Frequently, women are referred to cardiologists during this time, but it's because of changing or declining estrogen levels in many cases. And as long as they're without pain and shortness of breath, and they resolve pretty quickly, it's usually associated with hormone changes and resolves very quickly when starting HRT. Heartburn, being overweight. A lot of women complain of weight gain during the perimenopause and certainly postmenopausally. And this is linked to what we call insulin resistance and metabolic disease. And as I've said, it goes into a bit of a negative spiral, actually, with we put on weight, we don't feel as good, we don't move, we don't eat healthily, and then we produce estrone, which is not as helpful for us. And so it's important to manage lifestyle, nutrition, exercise during this period and beyond. Now, for me, one of my most serious presenting problems, and continues to be actually, it's the one issue I know that I'm not doing well with when my estrogen levels drop, is joint and muscle pain. It's usually more common in the morning when your estrogen tends to be at the lowest. And we also know that estrogen plays an important role in reducing incidence and severity of osteoarthritis. I had a hip replacement last June. Whether that's connected to estrogen or not, I just know that joint and muscle pain is my indicator that I'm not getting enough estrogen and I need to up my pumps. Low libido, very common. It's not just about wanting sex, it's also the pleasure that we get from sex, intensity of orgasms, intimacy, and it's driven by our hormones, primarily testosterone, but also if we're experiencing vaginal dryness, it could be painful. So all of that needs to be put right. And as I mentioned, we're going to talk about that later in the series. Our low mood, anxiety and depression is often due to serotonin falling, cortisol rising, and actually by putting us on antidepressants, that then has a further effect in terms of reducing libido and our sense of self, our sexual self. So important to recognise what a common symptom of perimenopause and menopause our psychological symptoms are. Now, migraines are generally worse during the perimenopause if you've been a migraine sufferer compared to the menopause, and it's due to the changing hormone levels. And I've not even got onto the most significant symptom of all, which is hot flushes and night sweats. So before I go into those in a bit more detail, I just want to talk about how we monitor against symptoms. We do take an extensive clinical history, and what we do is ask you to fill in a menopause symptom questionnaire. There is a wonderful app on the Balance app that can allow you to track this on your phone if you want to. But otherwise, when you come into clinic and when we monitor you over a period of time, we ask you to complete this. And this really helps, first of all, for you to understand how the perimenopause and menopause is impacting your body, to see the plethora of symptoms that we can get, but also it can influence some of the decisions we can help you make around, for example, hormone replacement therapy. So down to hot flushes. The exact cause of hot flushes is not known, but thought to be related again to changing estrogen levels, impacting areas of the brain involved in maintaining body temperature. I think that's the hippocampus, and it can also cause night sweats, which are essentially hot flushes but happen at night. And for those that you have had them, and it does affect, as I say, almost 8 in 10 women, you end up particularly with dripping between your breasts. It's a really quite unpleasant feeling. Your brain thinks you're overheating, starts to cool the body, your temperature rises, blood vessels dilate to increase blood flow, and then your heart pumps blood to those dilated blood vessels. So you might feel your heart rate increase. You feel heat in the core, dizziness, shortness of breath or palpitations. It's really not nice. Heat escapes from blood vessels with a flush to the chest, neck and face, and you sweat to get rid of the heat. And then it goes in a few minutes or seconds for some. So a really unpleasant feeling. A really good indicator actually of whether when you're on HRT, you're getting enough HRT, because we really can gauge quite quickly whether your estrogen is being balanced and you're getting enough. And night sweats can be a breakthrough symptom if absorption of HRT is not working as well as it could. So now on to the impact of menopause. I think we've got a pretty good idea. As individuals, we'll be going through our own journey, or you might be supporting somebody who's going through the perimenopause and menopause. But I think it's fair to say it can have a huge impact on women. I vaguely remember my mother going through it. She'd disappear into the toilet and just sort of cool herself down, but she didn't really talk about it. And I think the number of celebrities who are now talking about it on social media, on television programs, can only be a good thing, because it has a huge impact on women. But it is a complicated relationship. A lot of us think we need to sort of man up, which is a terrible phrase, particularly in this context, and just get on with it. And actually, you know, there's some sort of medal at the end of it if we've got through without having HRT. I think we're going to see a massive shift in the way we think about menopause. Rather than thinking about what would make us go on HRT, we're going to start having a dialogue about why would we not go on HRT? And of course, there are some reasons why we might not, but I think we need to shift the conversation. Now, 3/4 of women in this country say that the menopause has caused them to change their lives. More than half say it has had a negative impact on their lives. And this particular survey done by the British Menopause Society on 1,000 people, 2/3 of which were women, a third were men, really started to look at what impact it could have. And 45% of women said work can be a struggle. And 1 in 2 had to have a day off work because of their symptoms, wouldn't tell their employer why. Thankfully, that's changing in workplaces, and the recognition of what an important resource women in their 40s and 50s and 60s are in the workplace, and how important it is to keep us healthy and productive, is starting to enter work boardrooms and be discussed. Over half of women said menopause had affected their sex lives. I think it's probably more than that, given all of the symptoms. We lose confidence, we lose self-esteem, we feel less attractive, our libido is affected by our hormones, we get dry vaginas. I mean, it's a wonder we have sex at all. Anyway, moving on, what can be done? So thankfully, we have hormone replacement therapy. Essentially, what we're doing is replacing the estrogen we used to make ourselves. And in fact, modern HRT is body identical. So all types of hormone replacement therapy contain estrogen. If you still have a uterus, then you require progesterone, as we talked about earlier, usually as micronized progesterone, which is branded as ertagestrant in this country, or a synthetic progestogen, or you may have a Mirena coil, which delivers an amount of progestogen into the uterus directly and is very effective at preventing the thickening of the lining of uterus. We give progesterone for women that have a uterus because there is an increased risk of uterine cancer if the estrogen goes unopposed. It's very rare, and in fact, women on HRT are less likely to have an endometrial cancer than women who don't take HRT, but we do monitor it. Now, the progesterone element of the HRT, if you need it, in other words, you don't have a Mirena and you still have a uterus, is given either sequentially, in other words, for 2 weeks or 12 days of every month, or continuously. Now, how we give it very much depends on whether you're still having natural cycle periods, and continuous progesterone tends to be once you've completed your periods or they're very, very sparse. So your healthcare provider will come up with a plan depending on your own individual history and journey and where you are. We do give estrogen-only HRT in women who don't have a uterus, and those who have progesterone and estrogen, it's called combined HRT. So quite straightforward. Now, it can be given in various ways. The safest way to give estrogen is through the skin, and to give progesterone orally or to have the Mirena coil. Transdermal, in other words, through the skin, can then be a patch, a gel, or a spray. And in all of those cases, in this country, it's 17-beta estradiol, which is body identical. It's actually produced by plants, and it's the most natural way to replace hormones. Now, some women will be taking oral estrogen, and there may be a reason for that based on their history and journey with HRT. But it's important to note that if you take something through your mouth, it has to go through and be absorbed by the gastrointestinal tract into the bloodstream, and it always goes through the liver in what we call first pass metabolism. That then changes the hormone makeup and means it works differently. That can lead, and we'll talk about this in a minute, to increased risk of blood clots. It's still very low, but we wouldn't give oral HRT, oral estrogen, to women, for example, with a history of migraine with aura, or to women who've had a history or have a high risk of blood clots. However, estrogen given through the skin is completely safe for those women who've had a history of blood clots or have migraine with aura, because it avoids the liver. Testosterone, we can also prescribe. As I said, we'll talk about that later on in the series. It is off license, in other words, or off label. In other words, we don't have a licensed female product for testosterone. Let's hope that changes. but we certainly have options that we use in this country. And then vaginal estrogen is part of our replacement regime for women who have urinary symptoms and vaginal and vulval symptoms of the perimenopause and menopause, and more of that in our third session. So what are the benefits of HRT? Well, there are two main benefits, and hopefully the story has made sense in that if we replace our missing hormones, it corrects the hormone deficiency, and that eases physical and psychological symptoms. A bit like if you had a low thyroid function, we would replace with thyroxine, or if you had type 1 diabetes, we would replace your missing insulin with insulin. Now, it can take a few months and some tweaks along the way to get your HRT right, but it can make a huge difference. And I also want to talk about protecting long-term health. The inflammaging that I talked about earlier, the accelerating aging caused by declining estrogen, increases future risk of disease, and that includes cardiovascular disease, so risk of heart and stroke, diabetes, osteoporosis, and Alzheimer's, as well as clinical depression and even some types of cancer. And Parkinson's has also been shown to increase in women who have an early menopause. Now, the scientific evidence now shows that HRT benefits outweigh any potential risks with using body identical hormones, and that we know that women who start who have HRT, and this was a study done in 2022, so very recent, found that combined HRT had a 9% lower risk of death from all causes than non-HRT users. Now, you're probably thinking, but what about breast cancer? And I'm going to come on to that in a moment, but let's just make sure we properly understand the benefits associated with HRT. Now, cardiovascular disease is the leading cause of death in women, and the risk notably increases after the menopause. So any advantage we had over men up to the menopause is lost if we don't replace our estrogen. Now, the risk is about 5 times higher after menopause than before, and heart disease is the leading cause of death in postmenopausal women. It's also misdiagnosed frequently, as we often present with different symptoms to men. Prognosis after a heart attack is worse in women, but by correcting the hormone deficiency, HRT can help to lower the risk of heart disease. And it helps to adjust cholesterol levels and also can help with things like blood pressure, etc. Now, women who start HRT during the perimenopause or within 10 years of menopause happening have been shown to have a significantly lower risk of developing heart disease compared to women who don't take it. The evidence is less robust for older women. So in other words, if you start more than 10 years after your menopause, it would be definitely based on an individual risk assessment and discussion, but it's just at the moment we don't have the evidence. There is an indication that it benefits older women too in terms of lowering their risk. Now, just interestingly, improving lifestyle can reduce death from heart disease by 12 to 14%. So there is no doubt keeping a healthy weight, not smoking, exercising, eating good foods helps with preventing heart disease. But currently, statins haven't been shown to be beneficial in women, and that's a lot to do with the way trials are conducted. And taking HRT can reduce death from heart disease by 30%. Menopause is a cardiometabolic condition. This means that biochemical changes occur in our bodies when our estrogen levels are low, and it causes increased insulin resistance, one of the reasons we put abdominal fat around our middle on, risk of metabolic syndrome and type 2 diabetes. Women on HRT have a 20% lower future risk of developing bowel cancer, and as I mentioned earlier, HRT has been shown to reduce death for women taking HRT compared to women who don't. So what about the risks? Nothing in life is without risks. And so it's important for all of us making a decision about whatever medicine we're taking and lifestyle choices that we make sure the benefits outweigh risks. We know for the majority of women, benefits do outweigh the risks, and that's evidence-based, yet many of us are reluctant to take it. Why is that? And if you do want to take it, some of you might have met resistance from some healthcare professionals. So there's been this nagging doubt that HRT is too risky and causes specifically breast cancer, but it's incorrect. And I'm going to talk you through why. Now, during the early years of my pharmacy career, HRT grew in popularity. And I think it's fair to say I was dispensing HRT to pretty much every menopausal woman. But in the early 2000s, everything changed. In 1993, the Women's Health Initiative began a clinical trial looking at the health effects of women taking estrogen only or combined HRT compared to placebo. Now, it was using pregnant horses' urine estrogen derived product, so an old form of estrogen and a synthetic progestogen. And sadly, the conclusions were leaked to the media without results being analysed first, in other words, being peer reviewed. And later analysis of data revealed that a link to breast cancer that had been leaked to the media was not statistically significant. In fact, that aspect of the trial has been discredited. And in fact, subsequently, estrogen-only HRT has been subsequently shown to be associated with a lower risk of breast cancer, but of course the damage has been done. So most types of HRT do not increase the risk of breast cancer. The only type that might have a very small risk is the HRT containing both estrogen and the older synthetic progestogens, and only if over 51 years old. And the risk is associated with the type of progestogen and not the estrogen. The risk there is less than if you drink a couple of glasses of wine each night. And there is a significantly increased risk if you are overweight or obese. And this lovely infographic shows that really well, that actually based on combined hormone replacement therapy, the second line down, you'll get 4 extra cases per 1,000 for women aged 50 to 59. It's akin to the combined oral contraceptive. It's less than if you drink 2 or more units of alcohol a day, and considerably less. Your risk doubles if you are overweight or obese, so even more reason. But you can mitigate some of the risk by keeping healthy, by not smoking, by not drinking excessively, by taking exercise per minimum of 2.5 hours, moderate exercise each week. And actually, if you don't have your uterus, you are at a lower risk from estrogen. So I hope that's put to bed the risk associated with breast cancer. Blood clots we've already talked about. There is no additional risk with transdermal estrogen, in other words, given through the skin. And as we mentioned earlier, women who take any type of HRT have a lower risk of dying from breast cancer, from any cause, but also from breast cancer compared to women who don't take it. So as we come to the sort of conclusion of this talk tonight, I want to touch on lifestyle, because there are a number of different things that we can do to support our bodies through the menopause and beyond, whether we take HRT or not. My belief is HRT is one of the biggest choices we can make to protect our bodies if we're able to take it. But there are other things that we can do to support just how effective HRT is. We could give you all the hormones, but if you're living a poor lifestyle, you'll still feel pretty rotten. So exercise, one of the best forms of medicine. And of course, it's important not to over-medicalize the menopause. So a variety of exercise, it's good for the heart, it keeps weight down, it lowers blood pressure, it's good for the mind, for our mental health, reduces risk of dementia, it gives bone protection, aids restful sleep, aids digestion, daylight. The whole thing is incredibly important for us, and it makes us feel good. It gives us strength, it helps with balance, it reduces frailty into old age. Frankly, at 85, I want to be able to wipe my own bottom and to feel I can move and not need to grab chairs and tables to be able to do so. But what I would say about exercise is small wins are better than doing nothing at all. Move after eating, put habits in place, establish a routine, exercise with friends, make it fun, go for walks, get the fresh air. And actually, the first step is the hardest. Put your trainers on, put your kit on, and just do something. It's going to be better than nothing. Nutrition, the next best thing we can do, or the next best thing, they're all important, but we are what we eat. Watch sugar, sugar is pretty toxic to inflammation in the body, particularly as we get older. A Mediterranean diet is now evidence-based to be the best we can do for our body. Variety and balance in what we eat, mostly plant-based, and losing the sort of saturated fats, the dairies, and the red meats, and replacing with fish, oily fish, and olive oil. Mindfulness, looking after our mental health, really thinking about how we can best look after ourselves, creating space. I often say to women in their 40s and 50s, put your own life jacket on first. We're so set on helping other people, whether that be elderly parents, siblings who need support, or our growing family and children, not so small children as well. We often forget to look after ourselves. So it is really important to put your own life jacket on first. Calcium and vitamin D. I didn't really mention the importance of estrogen on bones. I should have done. We're at high risk if we don't have HRT. 1 in 2 women will develop osteoporosis and potentially go on to have fractures, spines crumbling, falling over, breaking hips. The mortality rate after breaking a hip is in your 80s is really bad. 1 in 2 people will die within a year of having a hip head of femur fracture, so in their 80s. So it is really important to keep our bones healthy. And in fact, estrogen hormone replacement is actually a first-line treatment for HRT. So it is indicated for the treatment of osteoporosis. It's getting late in the day. Sleep, really important to look after ourselves, look after our gut health, reduce alcohol consumption. Alcohol is really not good for us, and is often used as a bit of a support mechanism. But if we can get our hormones right, then we can look at all of these brilliant things to keep us healthy in the future. Health screening, your poo tests for bowel cancer when they come through, they start at age 60. Your mammograms, checking your breasts, and your cervical smears, really important to keep well. And then finally, you could still get pregnant. Until you've reached the menopause, you can still get pregnant, even if your ovaries are failing. So that's one of the reasons why the Mirena can be really effective during this time. It can reduce bleeding. It can be effective. It is an effective contraceptive, and can protect your uterus if you're using HRT. Some wonderful resources available for thinking about mindfulness, the right amount of physical activity to have, and also great diets. So we can send you those through. And I would say be informed as much as you can during this period of your life to keep healthy, to have a really brilliant 6th decade, 7th decade, 8th decade and beyond, keeping yourself as strong and well as possible, mentally, cognitively, physically, sexually. These 2 books, absolutely recommend. Dr. Louise Newson, we follow all of Newson Health's guidelines in the practice that we do. She's changing the face of menopause care with the research that she's doing, and a great book around estrogen that I'd highly recommend as well. So in summary, those of us born with a uterus will menopause, whether that's abruptly, if we go through a surgical or menopause, or naturally in our late 40s, 50s, if we're average, earlier for many. It can be a difficult period of change for most of us. Hormone deficiency associated with menopause leaves us very vulnerable to disease and long-term health issues, and HRT is generally safe for women and more so offers long-term protective health benefits. And optimizing your health is more than just HRT. It's a partnership between you and your healthcare provider and the life that you choose to live. So I can't see many questions that have come up, and we are running close to time. So I will follow up with any questions if you want to email them to us. We'll answer those questions and send them to the group of you that have attended. And I just want to call out really our next in our women's health series, the perimenopause, the genital urinary syndrome of the menopause, basically dry vaginas, vulvas, urinary tract infections, sensitive bladders, leaking, incontinence, etc. HRT on the 21st of June and testosterone on the 5th of May. And then I will check the questions because I can see one's just popped in, whilst leaving that on the screen, just to say we're very happy to help at Remedy Health. Just give us a call, send us an email, or book in a consultation. And I'm just going to check the questions. So, yeah, a couple of questions come through. Will we get a reminder for the next sessions? Yes, absolutely. We'll, you can go on to Eventbrite where you booked in for this one and book yourself in for the next ones. We'll send you through a reminder. I've got a question from somebody saying I sent in a question when I registered. I'm really sorry that hasn't come through on the system, so we'll check that. If you want to send it through now, I'll just have a look. Otherwise, we'll send you an answer to that personally. I've also been asked, how does sequential HRT work? So essentially, you use your estrogen every day, whether that's patch, gel, spray, and you take your progesterone, usually micronized progesterone, for 12 to 14 days each month. Now, it very much depends on where you are with your periods as to whether that's linked into your natural cycle, if your periods are still reasonably regular, or whether we just simply choose for ease a day of the month. So quite often we'll say, let's say from the 1st to the 14th of the calendar month, take your progesterone. You take 2 ertagestrans, usually 200 milligrams of micronized progesterone for those 12 to 14 days. And that compares with 100 milligrams continuously. So that's one every night. We take progesterone just before bedtime on an empty stomach. That means it's going to be best absorbed. And also, because progesterone is a sedative hormone for many, it'll help you go to sleep. So hopefully I've answered that question. Thank you so much, everybody, for attending. I'm going to sign off now. A reminder that you'll get the recording, and we'd love to see you at the next sessions. Thank you very much.